Then I'll start with introduction with Dr. Bari.
I think Mr. is still in operating, so we can proceed with Mr. Thalava's case first, and then.
Okay.
Mr. Sunil Nikoshe and Mr. Thalava can be presenting now. Yeah.
Hi, good morning.
Hi, good morning. It's Mr. Thalava here from Manchester, United Kingdom, and this is Sunil. Sunil is planning to prepare he's planning to present on an interesting topic, Targon FN fixation for intracapsular fracture neck of femur, and our experience in a district general hospital. He's going to touch about a bit about the biomechanics as well as the implant design and how it was developed and what are our rates, and then we can have a good discussion. Handing it over to Sunil. Thank you.
I thank you, Mr. Thalava. My name is Sunil Nikose. I work in Thameside General Hospital, the Greater Manchester in United Kingdom. Hello, everyone. I hope we are all okay. Thank you, Mr. Dev Kumar. I don't call him Dev Brata, I call him Dev. So, yeah. So, I think somebody from the management team or video recording should be sharing our presentation, if I'm correct.
Oh, should we share the presentation from here?
I will host has disabled participant sharing screen.
Okay, just a second, sir. Just a second.
Yeah.
Yes, sir. Now you can do.
I will just try it. Yeah, I think so.
Okay.
Is it visible to everyone? This presentation?
Yeah, it is visible to me, Sunil, but I don't know about Dev and the
Yes,
team in India.
it's visible. Yeah, it is visible.
Yeah.
Clear.
Am I audible to everyone, please?
Yes, yes, clear. Nice
Yes.
and clear.
Thank you so much. I think this is something what most of the people in India also nowadays know. It is a Targon femoral neck device. Am I okay to start, or shall we wait for some time, Dr. Arnab?
Yes, yes.
Yeah, thank you so much. Thank you, West Bengal Orthopedic Society, for giving us a chance to come here on this platform and share our small experience for this newer device. We are neither the promoter of device nor the marketeers. We have been using this device for quite a few years now, and we are just trying to share our experience. For some of you, that might be a little bit newer device here. So this is known as a Targon femoral neck device for intracapsular fracture neck of the femur. So, sorry for that. If we can see, we are all working in the DGH District General Hospital in the United Kingdom. And this is a dynamic locking plate, what is called as the Targon by the manufacturers. And it clearly shows that there are 4 proximal holes for the neck of the femur with different permutation on combinations, although the fixed angle there, and 2 variable golden screws for the metaphyseal region fixation. So we are going to share our small experience in this. Mr. Thalava, you can just stop me when you are thinking that I'm moving here and there wayward. So please feel free to shut my mouth. Yeah. So in United Kingdom, hip fracture is actually a big burden. You must be seeing that or listening in the news nowadays with Rishi Sunak and Liz Truss contending for the post of the Prime Minister. They are actually trying to reduce the cost of NHS and every discussion most of the time is going on the social care as well as the health. So we have around 130,000 hip fractures over a small country like a United Kingdom, and the cost is over 3 billion. And this is only the cost of the surgery. We are not taking the cost of the social care and the aftermath of morbidity related to it. When I have a look at the meta-analysis over the past few days, 2021 and recently, the Parker and Stockton, historically and presently also there are some 18 different implant itinerary from 30 studies, and none of them actually shows the superiority over each other. And I have written a small Parker. Parker was the one person who actually tried to develop this Targon device. The sliding hip screw, every one of us knows, and multiple cancellous screws. We have learned in the postgraduate thing that these are the fixation of choice, and most of the time they have a good result in the literature. Means there has been a comparison with dynamic hip screw, sliding hip screw, dynamic hip screw versus an multiple cannulated cancellous screw. There has been various literatures telling us how to pass on the cannulated cancellous screws. There has been something in the recent literature coming from the Korean thing that we should be passing a vertical screw from the calcar from the lateral aspect. So plenty of thing going on with this. And the options are quite straightforward for an end displaced fracture of neck femur. Compression hip screw. Some people prefer, oh, I am good at dynamic hip screw, I'll do a dynamic hip screw only. Some people say, oh, I will just want to prevent the derotation here, so they put an anti-rotation screw. And DHS is a fantastic device. It is a time-tested device. The age of the device is almost as old as most of us. And it's like 40 years, but unfortunately, the screw size is 12.5 without any improvement. Few people debate, okay, there is so much of the bone loss and so much of the destruction that endosteal vessels are destructed and subsequently causing an localized area of avascular necrosis intramedullary followed by a non-union and avascular necrosis. So options are, yes, they are limited for displaced fracture, especially in elderly population, but the treatment of choice for less than 65 years physiological age, active individuals are usually fixation by whatever device the surgeon is competent with. It depends all on the training of the surgeon. It depends on the resources available in the hospital, the cost, whether it's a private or a public sector. Some people, yes, prefer, okay, physiologically looking elder, so they do a hemiarthroplasty. In India, the bipolar hemiarthroplasty is quite commonly done. Recently, in big cities like Kolkata, yes, people agree that total hip replacement in few setup like CMRI or something like this. There is a plenty of literature why these screws are failing, and each manuscript quoting that, oh, we have done this thing and it sounds better than the different thing, and like that and like that. So mainly there are some patient factors which we don't have any control. We don't have a control over age of the patient. We don't have a control over the fracture morphology. If we take the Powell's classification, we don't have any control over Powell B and C. And even we don't know whether Powell A, Powell's type 1 is going into union or avascular necrosis, although we say that, okay, the line of forces are in the direction of calcar. Bone quality, yes, we say that when we are trying to fix 65-year-old, They are less osteopenic, but so much of the medications here and there, we don't know what is going on. The only thing what we can control is choice of the fixation device. That is limited in some centers. Yes, I can understand it is limited by the cost, it is limited by the availability and the itinerary and the nursing assistant or something. Surgical technique is one thing what is in our control. Everybody has a learning curve with everything. Some people say that this is working very good with me, this is working not very good with me. Usual surgical technique should be reproducible in most of the orthopods population at whatever grade, whether they are a specialty grade or the consultant or associate specialist or somebody like this. So you can see on the left side a left fracture neck of the femur, fixed nicely with screws. We don't know, the neck shaft angle has been reconstituted nicely. AP is shown, although the lateral shows also the best. The surgeon tried to do something like a fully cannulated cancellous screws there, and they thought that the fracture will ultimately go in for a better union without any non-union or something like this. Unfortunately, things are not under our control most of the time, and it failed ultimately at the end of 7 to 8 months with a constant follow-up. Whether it's a failure of the fracture, whether it's a failure of a surgeon, whether it's a failure of surgeon or implant is quite debatable. And we can see that on the right side, there is a picture which shows that usually the line of weight bearing is directly related to the shifting of the implants there. Although there are three cancellous screws, 6.5 into 3, it still fails. So we don't know what has happened to the lateral wall, what has happened to the fracture. How we think some people may say that it was a Powell's type C fracture, where the shear forces were pretty more than the compressive forces, but that's all a pattern matter of debate throughout the long period. So there has been plenty of advantages and disadvantages of these fractures. One of them, it provides a very good proximal hold, and this has a concept of lag screw effect, where the head of the femur is pulled toward the shaft, but the surgeon does not have a choice over the collapse of the fracture or the neck getting into collapse and subsequently it fails. Small size is an advantage to most of the people, because they say, oh, you are disturbing the endosteal blood supply very, very less. So in that scenario, okay, the chances of avascular necrosis quite low. Probably some people say, oh, we are drilling like a cannulated drill bit. So probably this is providing a core decompression type effect and union would be enhanced. But then there is still a poor lateral hold. Fracture ultimately tilts into varus in most of the cases where it does not go for union in an appropriate time. And most of the patients, if there is a collapse of the fracture or absorption of the femoral neck, then there is a backing out of the screw on the outer aspect. The patient might feel something protruding. If it does not back on the outer aspect, then the patient will have a painful and a stiff hip due to screws going through the acetabulum and through the hip joint. Now, this is all, we don't have an immediate post-operative X-ray for this patient, but ultimately it fails usually into varus, whatever we try to do, especially if we don't take a good post-operative care. And by some authors, this has been described as a weak fixation or a provisional fixation, like what a K-wire does to a distal radius. But the distal end of the radius is, yes, weight-bearing bone, whereas the hip joint is a weight-bearing. So that's the difference which is there. So early fixation failure is because of the comminuted lateral cortex, which might still be there in the presence of intracapsular fractured neck of the femur, especially in osteoporotic bone. We are trying to find out our way. We drill, we finally pass 3 screws, but some people will drill 5 on the outer cortex. Some people will drill 6, and ultimately they join together and the lateral cortex breaks. So the bending and the vertical shear forces or the loading, we are not going into the detail of this because everybody of us know that how the weight bearing occurs through the pelvis from the hip. And so mainly in fracture patterns, Powell 3 and 2, especially in garden displaced fracture, which have been reduced adequately. Also, the vertical shear forces are quite high. Hip screw, yes, traditional. Everybody of us know that hip screw is a better biomechanical, like we can call it as a bodybuilder device, like having a good biomechanical strength and good fixation wherever it is used. It has been used since 1970s probably. The main aim was to use it for intertrochanteric fractures of the hip, but ultimately people thought if it is being useful for the intertrochanteric fractures of the hip, where the forces are very, very high, why can't it be used for the intracapsular fractures of the hip, where the forces are quite low? But then what happened? There is a single large screw of 12.5 mm diameter. Plenty of manuscripts debate that there is plenty of loss of blood supply and trabecular system is destroyed in the meantime, causing loss of the endosteal vessel, subsequently leading to avascular necrosis, fracture, collapse, and varus non-union or failure of the device. So it gives, although a better impaction and compression. If we do it in single, some people say that we just pass an anti-rotation guide wire and then fix the screws, and then we don't need to worry about it because we have kept the head of the femur not rotating like this. So, but it has got some amount of rotational malalignment. It sometimes works as a bucket in the well and it's get loose. So there are plenty of theories about this failure, but most of the time there is some rotational malalignment, subsequently fracture, collapse, and the hip joint and penetration into the hip joint. So this is all, these are all fracture related pattern where probably the surgeon did the best, and unfortunately so much of the neck collapse, we can't see the neck, and one of the screws has gone inside, the bigger one has backfired because it was a collapsible screw. So there are advantages of anti-rotation screws. There are these disadvantages of anti-rotation screws with penetration into the joint and something like this. AVN after fixation really not under orthopods or our control. So we are just a mute spectator. Keep on following the patient and letting them know, probably we'll let him arrange the funds for a total hip replacement. And once he's okay with that, then we go ahead and do something. So coming with that, this device like Targon FN was started developing in some part of the Germany, northern Germany, by a few of the references. If you take Parker and Brandt, they thought, why not use the advantages of combination of sliding hip screw and multiple cancellous screws? So if we use two advantages of two implants, probably they thought, oh, it will be an improved implant and with a better biomechanical properties, whereas the torsional strength would be increased. So they did some cadaveric analysis of sliding hip screw, multiple cannulated cancellous screw over all the region, as well as the Targon femoral neck device. And I think Mr. Barry has joined. Good morning, Mr. Barry. Welcome.
Good morning. Thank you.
Yeah.
Carry on.
So they had done a multiple cadaveric analysis there, and they had seen that the load to failure was significantly higher for this new implant devices when the sliding hip screw was, as well as the multiple cannulated canceller screw was compared. So subsequently, they thought, let us use these two advantages because they are the two common devices, and they came on with one device, what is known as a Targon femoral neck device. As you can all see, multicolored device. Yes, it's a fancy device, might be little costly. So it's having a 5-hole here. One of them in the center is for a guide, is for holding the plate to the jig, and 4 variable combination of the locking compression screws. So basically, they use the advantages of telescoping screws, where 4 of the 6.5 millimeter of the telescoping screws could be passed, and 2 4.5 bicortical in different direction, rather divergent, to get a better hold of the lateral cortex, as well as prevent the stress risers and future fractures in the subtrochanteric region. So these telescoping screws actually have an gliding capacity of around 10 to 20 mm, like 1 to 2 centimeters, in case the neck collapses after the fracture or there is a fracture absorption. So this is all the product device. We need not discuss so much of the product device, but the authors say that it's quite a simple surgical technique. Mr. Thalawa, Mr. Barry has been doing this regularly. I understand they might have had a long learning curve or a short learning curve. Both of these guys are intelligent, so they might be having a shorter learning curve, but my learning curve is a little bit longer. It's made up of a titanium alloy, what is MRI compatible. It offers, they say, simple technique, rotationally stable, what we want for an intracapsular neck of femur, and promising initial results. So this is like a configuration, and which is actually fixed to a jig, and then we take it from there. The distance between the central screw and the peripheral screw is like 9.6 mm, so it gives a variable thing, but this is mainly for the Westerner population. So if we calculate the short neck or the small neck of the Indian population, we can still say that, okay, 3 of the screws are going through the lateral cortex and completely through the neck into the head. Almost 4 might go posteriorly. So the choice is leave the posterior screw, because posterior comminution is there. It can still cause some of the problems. So this is like devices where it can collapse here 1 millimeters, controlled telescoping sliding, prevents the migration into the joint. And usually it's a 10 millimeter or 1 centimeter standard, but few surgeons, yes, if they want, they can take it to 20 millimeter sliding collapse. So this seems like a promising device. And although the learning curve is a little bit more, this jig, which looks like a large jig, it's kept outside the body, so you can see the amount of incision here is quite low. It is equivalent to a 2-hole.
Yeah.
Thank you. So
No.
so there is some targeting device, connection screws, and the handle, which are all outside the body. The advantages are proximal fixation with the multiple canceller screws, which allows for rotational stability, what all of us desire in intracapsular fracture neck of the femur, or any fractures for that matter. Even diaphyseal fracture, we don't want a single degree of rotation. Fixation to the lateral femur with a plate to prevent the stress risers and subsequently preventing the subtrochanteric fractures. locking plate and screw for extra strength. Means few people say 3 are okay, few people say 4 are okay, and prevention of backing out. Dynamic capacity allows 1 to 2 centimeter of the collapse, and all the screws are fixed together to allow for extra rigidity. We are not tightening the anterior screw first and the posterior second. We are actually half tightening few screws and then tightening one by one. Implant is made of titanium to allow the use for MRI if we feel that the fracture is going into non-union or avascular necrosis. And there is an alignment jig, what is available for most of the implants nowadays. So disadvantages we have described. So our primary objectives are a fracture fixation with Targon FN, although there are few surgeons who do a Targon FN here, few of them do a DHS plus a anti-rotation screw. We are aiming for weight bearing without pain and a radiological union which escapes the avascular necrosis of femoral head. Secondary objectives, we are not going to talk in length, the length of stay and complications and other blah blah revision procedure. There is a small one slide there. So patient demographic, most of our patients who were treated for intracapsular fracture neck of the femur fell within the range of 66 to 76. Few of them elderly than that. So we chose that probably impacted or grade 1 and grade 2 fractures should still be treated by internal fixation. Although there is a trial now going on in the United Kingdom in an elderly population above 60 age group that whether impacted and undisplaced fractures should be treated primarily by a total hip replacement. The results of the trial would be out in 2025. That is known as a Fruity 2 trial. So we have studied almost over a few years, 66 consecutive patients, and we are still doing it. And we can find that non-union 1 in the neck of the femur. Our results showed a good union rate and satisfactory outcome, although most of the surgery were done by the consultant grade. The original study by Parker et al. Parker was one of the person who was actually a promoter of this device and also shows that in undisplaced fracture, there is a 3% non-union, 15% non-union in displaced fracture, and 5% avascular necrosis. So we can all say that yes, intracapsular neck femur is still a mystery. There is still to be worked quite plenty on it. If it has to be seen plenty of things. So these are the number of, we had a few Garden 3 and 4, 19 plus 14, almost like 30% of them were displaced. Garden 2 were plenty in elderly population. So when we talk about the Targon FN device, the implant product brochure says that the initial guide wire is the key to get a successful outcome. Although everybody of us agrees that the anatomical close reduction is the guide, that is the principal thing which is guiding us to whether to do a fixation or not. But the second thing is to placement of the wires inside the neck of the femur, which should be central in both the location, both AP and lateral, central in the neck, central in the head over a period of time. So few of the cases very good for impacted intracapsular fracture neck of the femurs, where we get away with 3 screws. Most of the patients were treated by the 3 screws. Very few patients were treated by 4 screws, simply because probably the neck of the femur is little bit shorter than this, but we can use multiple permutation and combinations by this. Another of the patients, what we are trying to show, it is an immediate fluoroscopy. So the aim of fracture treatment was Anatomical reduction by any of the manuals, what works best, whether it's a lead better, whether it's a traction, whether it's a Flynn manual or whatever, followed by fixation with the Targon FN device. Ultimately, this patient was fine. This is one of the Garden 4 fractures treated with an, treated with again anatomical reduction followed by a fixation. And ultimately he went to heal on well. One of the patients, although the fixation looks very, very good, MRI done at the end of 8 months was like a involvement of the anterosuperior part of the femoral head with avascular necrosis. We can see probably the fracture is uniting, but ultimately the head is going in avascular necrosis and he might need further reconstruction procedures. So we had some displaced fracture which had a non-union. Everybody were treated with a total hip replacement, and few of the patient had avascular necrosis leading to secondary osteoarthritis. Although none of these patients, there was a penetration of the implant into the joint. That's a good thing, which is quite a disadvantage with what we see with DHS and anti-rotation screws. So we basically recommend, or the literature recommends, that we should be careful in selecting the patient. Avoidance of internal fixation for displaced intracapsular fracture in elderly population. It all depends country-wise who are elderly. I understand in India we take like 60 as an elderly population. Here it's more than 65 or something like this. There is a learning curve, so cadaveric courses related to Targon would be advisable. Strict adherence to the operating technique and the manual of the fixation. Adequate reduction, or anatomical, I would say, accurate fixation and follow-up at least 2 years. In conclusion, this dynamic locking plate, what we were telling as Targon FN, offers a superior outcome when I'm seeing at the literature at this present date in comparison with alternative implants like sliding hip screw, dynamic hip screw plus anti-rotation screws and multiple cancellous screws. And the literature shows a higher non-union and revision rates with multiple cannulated cancellous screws and a dynamic hip screw and CHS, although it does not affect the osteonecrosis and other non-orthopedic complications rate. So we need to decide according to the local implications, specific conditions for the clinical implementation. Plenty of references. I just had collected few of the data today morning. So this is all newer data, what we were trying to give it. Thank you so much for your kind attention. We are open to discussion. I would, before we start discussion, Mr. Thalawa would like to comment something.
Thank you very much, Sunil. And from TAME side, from all the department, we thank Dev, Kumar, and Arnab for giving us this opportunity to present it to you. This is a very small study. The number of patients are only 66. However, it showed a promising results. Fracture neck of femur, even today, nobody knows the answer. If you compare the original article by Garden and the avascular necrosis rate, non-union rate, and the mortality, it's still pretty much the same. We don't have the answer. That paper was written in 1970s. This Targon fixation, the first patient I saw and I did, he walked the next day. That was a surprise for me. Literally, like, you know, when we do the fracture neck of femur with cannulated hip screw, we protect it. And this patient literally got out of the bed and walked right in front of me on day 1. And I was totally surprised at how much stability is provided. And that's how I started into developing my interest. It's got a steep learning curve. The most important thing is to get the screws in the correct place. The plate, the side plate has to sit on the femoral shaft. there are so many things when you're learning, you look at how things are developing. The two posterior screws, which Sunil showed in one of the x-rays, touching the posterior cortex, that actually provides fantastic stability. Sometimes the plate is off the bone and you think, oh my God, do I need to compress it? Sometimes you push the telescopic screw and you can actually use another screwdriver that goes in the outer screw into the telescopic screw to advance it right to the subchondral bone. All the screws except the gold screws are locked to the plate. So there is a lot of stability, and I think that helps. At the end of the day, and as an accurate anatomic reduction as possible, correct placement of the screws, and using this implant to your advice. These are the few things that are in our hands. We cannot select the patient. We cannot select the fracture configuration. We cannot control the osteopenia or osteoporosis the patient has at the time of presentation. We might be able to control the osteopenia and osteoporosis by giving bisphosphonates after the procedure, but before the procedure, we cannot. What is in our hands is the implant and the technique. Thank you.
Thank you so much, sir, for the very nicely elaborative talk. So there are a few questions that what was the threshold of open reduction in your series? How many times do you open the fractures,
I have never opened the fractures at all, honestly. Even in the Garden 3 fractures, by using the Ledbetter maneuver, we were able to reduce them. Once you have reduced, another trick which I have to tell you is the first guide wire that goes through the plate, you place it slightly inferior in the AP view and dead central in the lateral view. If it is dead central in the lateral view, see the forces that are acting on the head of the femur in the sagittal plane will be pushing the neck down. But in the coronal plane, the hip joints are placed behind the center of the body. So their center of gravity is at the back, the hip joint is in the front. So it imparts a bit of a rotational strain to the head. So the lateral guide wire in the lateral position is very important. It has to be central. And then the two inferior screws, even according to the originator, Parker, he says they should go very close to the inferior cortex and posterior cortex. And if you look at the fractured neck of femur, the next time you do a hemiarthroplasty, you take the head of the femur and look at it, there is comminution at the back. It is the posterior cortex that gets crushed. The anterior cortex opens up like this. The posterior cortex is compressed. That area, because it is compressed, needs the stability. So the posterior screw is important. So we try to get as accurate a reduction as possible. Valgus reduction, we all know, that is better than a varus reduction. And the rest is basically the telescopic screws allow controlled collapse at the fracture site. And the external screws which are fixed to the plate will prevent backing out of the screws.
Okay, sir. Thank you. Thank you so much. So thank you. So is Dr. Bari is online? So then we can proceed to the next talk.
Okay.
Yeah,
Thank you very much
so-
for giving us this opportunity. Thank you.
Okay.
Thanks. One thing before proceeding next things, we just missed one small introduction about Mr. Thalava and Sunil. So Mr. Thalava is a senior consultant orthopedic trauma surgeon and special interest in hip and knee, and he's our leader. He's HOD of Thameside Hospital in orthopedic, and he's a great teacher and regularly teaches FRCS, MRCS, and ATRS courses and other prominent courses as well. He has many publications and presentations globally, and he's a trainer of thousands of orthopedic surgeons in UK and around the globe. And he's the current trainer. And Mr. Sunil Nikoshe, he was a very senior surgeon in India. He was a professor, and finally he tried to explore his own life and came here for a fellowship in special interest in hip and knee. So we are working together. Can you, Arnab, introduce Mr. Bari, please, and then Jack will be presenting as well.
Yes,
Thank you.
yes, definitely. So today we are actually connecting from Bahrampur, Murshidabad, because this is the place we are actually organizing the Midcon of West Bengal Orthopedic Association. And I had once opportunity to meet and assist Dr. Mr. Bari in a surgery in Kolkata. Probably he remembers me at GD Hospital. So his introduction goes like this way. He's a boy from a village. He went to Bangla medium secondary school. He wanted to study chemistry and ended up with a medical degree. He was not very clever but loved surgery. He did his GP practice in rural Bengal for 7 years. Then he came to England for holiday, didn't want to go back without FRCS, and one thing led to another, next to next. Few years of general, then orthopedic training ended with few orthopedic degrees. He got entry into the specialist GMC registrar, finally found a consultant job, and his main area of work are clinical arthroscopic, lower limb reconstruction, and arthroplasties. Trainer of Deanery postgraduate rotational orthopedic trainees. He is an examiner of MBBS, MRCS, MCH, FRCS, Ortho, and European orthopedics. His ambition is to learn orthopedics. Over to you, sir. Welcome to Midcon 2022.
Mr. Bari, you need to unmute yourself, please.
Oh, yes.
Yeah.
Oh, thank you. Thank you very much indeed. I'm sorry I'm not with you or will not be able to be with you for a very long time. I'm in between cases. I have to start a hip replacement. Are you ready?
Whenever you're ready, sir.
Oh, okay. I'll be 10 minutes. 10 minutes. 5 minutes. 5 minutes. 5 minutes.
10 minutes.
5 minutes. Okay, so so basically the presentation that we are going to make is my baby really. In 2014, I was doing a periprosthetic fracture, and I wanted to. I was in two minds as to whether I should do a supracondylar nail or a plate. So I ended up doing a supracondylar nail. And then suddenly I thought, why not put an additional plate on it, neutralize it, and make it slightly more stable. Sure. So that's what I did, and that gave me an idea. I have then since done about 17 of them, and whereas there are some individual failures in metal work implantation in both the supracondylar and the plates. I have managed to reduce it to absolute zero in the 17. I have got no metalwork failure. So what I have is I had one infection, which I had to remove the metalworks and then put a revision total knee on her. And I had another instance where the plate was irritating the skin. She developed a bursa, so I had to remove the plate. By that time, the fracture had healed. So Jack is going to present it to you, the rationale of it, the objective of it, the techniques, and why should we be doing it. The main objectives are early post-op mobilization. I let the patient walk the following day. And the implant rate failure is very, very minimal. Those are the two objectives. Jack is going to tell you, and I'm going to leave it to Mr. Hammond, who is my registrar. And thank you very much for introducing me, Arnab. I hope to meet you again at the GD.
Yes, sir. Thank you.
Thank you. Jack, are you here?
Yep, I'm here.
Yeah.
I'll share my screen.
Okay, my friend. Okay.
Okay, sir. Thanks a lot.
So be a good boy. I have to scrub now.
Thank you, sir. Thank you for joining in.
Thank you.
Okay, just seeing if I can share my screen. Okay. Can you see my screen?
Yes.
Yes, please.
Excellent. Hi. So my name's Jack Hammond. I'm one of the trauma and orthopedic trainees working in Greater Manchester in the UK, currently working under Mr. Barry. So he's given a nice beginning introduction into the talk that we're going to do today. So essentially, it's as he's described, it's looking at combining supracondylar nailing and lateral femoral locking plates in complex distal femoral fractures, and looking at that as a new technique and looking at the outcomes, particularly focusing on the morbidity and the mortality associated with them and the metal failure rate. And so this was led by Mr. Barry, who's, as just described, one of the consultant orthopedic surgeons at Tameside General Hospital in the UK. So the objectives essentially, so looking back retrospectively to look at combining of these two constructs to see if they offer any advantages over single use rather compared to dual. So a bit of background. So we know that distal femoral fractures, they're very common fractures. They represent about 6% of femoral fractures. And they're generally as a result of either low energy fractures in osteoporotic elderly patients or high energy traumas, and are quite comminuted. Now, there's been different ways of treating these, which have been around for a long time. So the two most common being intramedullary retrograde nailing or lateral locking plates. And both have their advantages and their disadvantages. And primarily the disadvantages with the lateral locking plates is the perceived risk of metalwork failure, and that often leaves surgeons to be quite reluctant to let patients fully weight bear in the immediate post-operative phase. And I think we need to start looking at these more like hip fractures, particularly because of the increasing elderly population that's getting these, and the importance of early rehab, early mobility to try and prevent that morbidity and mortality, just in the same way that we do with hip fractures. And so trying to think of ways to try and allow patients to weight bear as early as possible. Obviously, intramedullary nails are, again, very common, and have been around for a long time, and they have a lot of advantages, but can be challenging, particularly in comminuted fractures or in certain types of prosthetic fractures, and particularly if there's only a small distal fragment to be able to get enough purchase to reduce the fracture and hold it. And there's becoming increasingly complex, these with the cohort of patients we're getting older patients getting these type of fractures. As I said, the bone stock is poorer, they have more comorbidities, and more susceptible to post-operative complications. And also with joint replacement surgery now, we're getting more and more complex fractures with involvement of prostheses. We know as well from AO have done a lot of studies at the mechanical properties, and we know that combining these constructs gives better axial and torsional loading than just the single constructs on their own. And they have their complications with non-union rates between the two being about the same, and in some cases of the literature being reported up to around 30%, which is, I was quite surprised actually how high that was, and metalwork and implant failure up to around 20%. So the whole idea of this is to try and resolve the issues of early metalwork failure, but also allow patients to fully weight bear to reduce that morbidity and mortality associated with it. So it was a retrospective study. So it looked back over all patients who'd had this form of treatments. This went over a period of 8 years. It was performed at a single centre by a single surgeon, Mr. Barry. And once we'd identified those patients, we took the electronic records. We went back to look for signs of clinical union, any post-operative complications, and also through the PACS imaging to look for evidence of radiological union as well. So there were 17 patients who had this done. And again, kind of suggesting how these are becoming increasingly complex. Over half, so 55% were involving or just superior to a total knee replacement. The other 45% were in native distal femoral fractures, with one of them being a distal femoral fracture that had been treated previously with a lateral femoral locking plate that had subsequently gone on to develop a non-union and then metalwork failure as a result of that. The average age was 74.8 years, ranging from 38 to 90, with a high, nearly 90% of those patients being female. And again, you can see from the mechanism of injury, much more common now to be low energy osteoporotic type fractures rather than the high energy, only 10% being high energy trauma. So we followed these patients up from the minimum follow-up we have is 12 months, but we have some that have gone up to 8 years, so 96 months. And 15 of the 17 patients had clinical and radiological union at a mean follow-up of 3.5 months. One patient still in follow-up. The rest of the other 16 patients have been discharged from follow-up now, And that one patient is doing really well. She's 1 year post-op, clinically and radiologically progressing as expected. So just a bit of some of the imaging. So first, you can see this was the distal femoral fracture that was treated with a lateral plate that subsequently went on to develop a non-union and then metalwork failure as a result of that. And you can see on the right, this is after intervention. So the failed metalwork taken out, reduced with a intramedullary nail placed in a retrograde manner, and then subsequently a lateral femoral locking plate to improve the stability. And you can see that, so clinically they were doing very well, and radiologically you can see the fractures united. This is just to demonstrate again kind of the different types of fracture this can be used with. So this was just a native distal femoral fracture, again with exactly the same technique, and you can see good evidence of radiological union. In terms of complications, so one patient had an infection, they had a total knee replacement, which subsequently went on to develop a prosthetic joint infection. And this obviously needed revising. So this was revising, all the existing metalwork was taken out, but the initial the distal femoral fracture had healed by this point. So it didn't actually affect the healing of that fracture, but it was just one of the complications. A second patient developed some bursitis over the lateral plate, and due to the irritation requested that it be removed, which was done. But again, after the patient had clinically and radiologically healed from the distal femoral fracture. So in terms of the technique, so the idea of this is that you using the retrograde intramedullary nail to achieve a gross reduction of the distal femoral fracture, and then the lateral locking plate to essentially fine-tune that reduction and also add to the stability of the fracture and to allow the patients to be able to weight bear and regain a better range of motion post-operatively. In terms of the technique, so it was a midline incision, and then curving at the proximal end, curving the incision medially. So quite a large exposure, and then a lateral parapatellar arthrotomy. And then there were two main advantages of doing a lateral parapatellar arthrotomy. So firstly was that you could accurately position your entry point for the nail, which was essential in terms of getting a good reduction of the fracture. And secondly, you could get anatomic reduction of the fracture under direct vision rather than relying on image intensifier, so you got a better reduction. So once that was done, then the entry point was reamed to about 15 millimeters, and the nail was advanced in a retrograde manner. And importantly, it was advanced parallel to the anterior and the posterior cortex, and this was to try and reduce any flexion or extension deformity of the fracture and get an accurate reduction. Once this was done, the distal portion, distal fragment was fixed to the nail, and then the lateral plate was placed to allow any fine tuning. And it was important this plate had to be placed eccentrically to allow for the passage of the screws next to the nail. So, and if this wasn't possible, then unicortical nails were used instead of bicortical. And then post-operatively, patients were kept in a cricket pad splint for 2 weeks, and this was really just to allow wound healing. And then after the 2-week mark, they were placed into a hinge knee brace and gradually increased their range of movement once the stitches were out. But most importantly, all patients were allowed to fully weight bear from day one. So on to the discussion. So, essentially, as I said, this is becoming a more increasingly common and increasingly complex type of fracture to manage. And it's all about trying to provide a balance of stability, but also allow physiological loading of the fracture and allow that to create an environment where the fracture can heal, but also allow patients to bear load through it and be able to get walking and weight bear. We know that through various research, particularly through AO, that the mechanical properties of a nail and plate together are superior to either a plate or a nail on their own. And again, similar techniques being shown elsewhere. So in distal humeral fractures, better outcomes with double or triple plating. And essentially what we were trying to do is take the advantages from each construct on its own and take those advantages to try and take the advantage from both of them to try and reduce the disadvantages of each in combination to be able to create a better stability and ensure weight bearing as soon as possible. And overall, from our results, we believe that this technique provides stability for immediate weight bearing with higher potential for healing, especially in those who are more complex fractures, so those with osteoporotic distal femoral fractures, those with high comminution and open fractures, those ones which are more prone to non-union. And our results show that we've maintained the alignment with all patients who have been followed up to a total of 8 years. and with radiological and clinical evidence of union at 3.5 months. So overall, we think this is an effective way of stabilizing complex supracondylar fractures to allow full weight bearing and reduce the morbidity and mortality associated with these. And this is just a final X-ray. This was actually the first patient who Mr. Barry was just on the introduction was talking about. So initially treated them with a intramedullary nail, and then actually at the end of the procedure thought about the benefit about the option of being able to put a lateral plate on to improve that stability. And that's what happened. And this patient's now been discharged. It's done really well. And obviously you can see with good radiological imaging as well. And finally, this is just a little video. This is actually the last patient. So this is the most recent patient who's had this procedure performed, and it was just to get an idea of a patient perspective in terms of satisfaction. So I'll just play you this.
My name's Mr. Barber. I'm 79 years old, and I fell at home on the 28th of July, just in the bedroom, and I fell in a heap. I could not move. I could not move at all. The pain was terrible. I came into hospital and I was told that I'd be in a wheelchair for 6 months to get over this. And I came into hospital, I had the operation, and within 3 days, I walked with a walker in hospital, and then I was allowed home. And since then, it's 5 weeks today since the operation. I'm walking myself.
Show me how much you can move. So this is only 5 weeks.
Yes.
Okay, so just go back again. Fantastic. Just sit down and show me this scar. Fantastic. And straighten the knee for me and bend it backwards.
I can't push it right back.
No, like this one. Like yeah, that's fine. It is going to get that.
Yeah.
So you're happy with the outcome?
I'm happy with the outcome, yes.
Okay.
I mean, I still get twinges and pain.
I did see you before the operation and say you're going to walk, didn't I?
Yes,
Yeah.
you said to me that it should be 3 days.
Yeah.
And you know, I was getting better, and you'd have me walk.
And you didn't believe me.
Get out of bed.
And you didn't believe me, did you?
I didn't. I do now.
Thank you, my friend.
So you can see there that, I mean, that lady, so when that video is taken, she's only 5 weeks post-op. She started walking and weight bearing 3 days post-op. And, you know, she's got excellent range of movement and has recovered really well from what is quite, you know, an injury with, you know, high levels of morbidity and mortality. So just a nice example of this a success story. And that's it. Thank you very much. Well,
Thank you. Any questions or no, team, please?
Thank you so much for the nice lecture. As of now, there is no such questions. So thank you all the faculties joining from overseas for their nice deliberations and participations. We're really honored that you spent time from your busy schedule and we shared knowledge with us. So thank you to Dr. Debabhrata Kumar, Dr. Sunil, Dr. Mohammad Bari, Dr. Jack, and everyone. Thank you so much. So may we say goodbye to you now and take care. Have a good evening. Thank you so much.
Thank you very much. Thanks.
Thank you. Thank you.
Thanks, Arnav. Thanks.
Thank you.